Thank you very much, Gary, Sherry, and Eric. Okay, so folks, we have ample time for conversation, discussion, suggestions, clarifications. Keep in mind, as Kristin pointed out, there's going to be a document, and so your contribution here is really valued and will live forever in that document. So think about how you can contribute. That's why you're here today. I think that we've got some really nice pieces of information to be dealing with. Gary sharing with us that information really levels the playing field. Information is power, but we're challenged with how do we then universalize routine use of accurate, unbiased information. Sherry's model of coach care and asking us, is passivity dangerous? Do we need to really believe that if patients are passive, they are in an unsafe situation? Virtual centers for coach care, what do you think about that? And then Eric's presentation, starting with system needs, but we need to make sure that when we start with those needs that we're addressing both the patient needs as well as the clinical needs, and that clinicians negotiating with biases and emotions, that's a really important issue. Okay, go right ahead.
My name's John Garden Earp. I'm retired. I have my doctorate in business administration and a career in science, and that doesn't seem to make sense, but it really does. My concern is the framing of the whole issue, and I think that everything that's being said about physician-patient interaction here is helpful and useful, but it's a tiny piece of the overall problem. When I took my doctorate, I concentrated on information technology, operations research, sometimes called management science or systems engineering or industrial engineering. All those terms basically mean the same thing. How do you get the system to work in an optimal way? And the implementing mathematics, aside from operations research, were statistics and accounting. And it's that bunch of things that needs to be brought together. And you need to look, I believe, at a healthcare management system that starts from the overview. We know the U.S. healthcare system is continually getting more expensive and less effective. This should be a major concern. It'll take systems engineering and expertise to help resolve that. At the individual hospital level, or even the individual clinician's office level, systematic management practices should be involved to try to improve the healthcare system. Just information technology is just a basic thing. I don't see a lot of electronic medical record systems, but the ones I have seen certainly never had any involvement by any professionally trained information technologist. And they should. I mean, the knowledge is there. We spend hundreds of thousands or millions of dollars training people to have the professional skills to do this stuff right. But in the healthcare business, we don't use those skills. And to me, that is a problem which, if implemented in a systematic manner, would incorporate what you're talking about with patient, caregiver, and provider interactions as measurable parts of an overall systemic effort at improvement.
Thank you. Thank you very much. Sherry, you're at an academic medical center. Do you want to have any comment about that? Any success stories that you could share?
No, because we're right in the middle of implementing an electronic medical record system, and it's really an amazingly difficult thing to do. And yes, because I think that that is the time when you can actually try and incorporate some of the personal health record information, but more importantly, teaching people how to use it. So if you intersected the technology that creates information about the patient with a training program for how to use it effectively when you come the next time to talk to your doctor, that I think really is important.
Lots of opportunity there. Sally?
Hi, thank you very much. Great presentations. My name is Salio, and I'm from Patients Like Me. Couple of comments. Sherry, I want to follow up on your comments. I actually went back through some of my slide decks recently and find things that I could refer to that I talked about in the mid-90s. And it is time for us to just really make some change and make it happen. So I oftentimes find myself pretty amused at the cartoons that are still relevant today that I was using in consumer-based education at the time, and it's just really a little distressing. Couple of tips, though. I am a palliative care specialist. I've spent most of my career with patients in their homes, sitting at their kitchen tables, listening to them talk to me. And one of the things that I actually learned really early on in my work was that I couldn't go in with my own agenda. I needed to go in and just sit with them for a moment and let them tell me something. And so what I would oftentimes do would be to open the conversation with, gosh, you look tired, what's keeping you up at night? Or just what's on your mind today? Now, oftentimes what I heard had nothing to do with their health or their health care or anything to do with illness. It was totally unrelated. What it offered me was an opportunity to hear how they framed things. I heard the words they used, and I heard how they would put phrases together. And then I would train myself to think about ways of taking that and give it back to them in similar ways that I would talk to them, so that I would no longer be talking in the way that Sally Oken, RN, would come in and talk, but I was starting to learn a patient vocabulary. Now, one of the things I'm quite proud of with patients like me is we have developed a patient vocabulary, and it's been from the patient's reports themselves. And what we've done is we've taken that in and we've coded it against clinical taxonomies and clinical vocabularies, but we retain the patient voice always. If someone wants to know what it translates to in a clinical term, we can tell you that, but we're more interested in what the patient actually said. So to your point, I think patients like me could become a degree-granting center for the Centers for Patienthood. I appreciate the comment. I think it's great, and I'm really looking forward to more comments from the patients from the audience. But keep that in mind. What's on your mind or what's keeping you up at night? And you'll hear and you'll learn quite a bit, because patients will tell you a lot more than you think. Thank you.
Thank you.
Hi, I'm Richard Thomason, Program Director with Blue Shield of California Foundation, and thanks for putting together a great panel. My question's actually for Eric, as the representative, I think, on this panel of organized medicine. So I'm wondering if you can... Disorganized medicine? Exactly. So I'm wondering if you could give us some more insight as to how physicians are viewing this drive, pull, push desire for more patient engagement, and what advice you have for those of us who are not physicians about how to create and support physician champions, whether in medical education and training or elsewhere, for this general effort.
Wow. I think there's a lot of things we can do. And you actually have an expert who's standing right behind you. So Mike Berry has spent a career developing tools. So there's clearly ways to leverage shared decision-making tools that Mike's developed in his work that I think could be very helpful. I think right now, part of it's honestly generational. The younger folks coming through see this as something valuable. This is something that's being much more inculcated into them. So it's like anything, if you kind of grow up with it in your training, it just becomes part of what you do. I think that training programs have gotten much more systematic about training people, and I think they've been able to show it makes a difference. The biggest challenge we have is not so much that we lack kind of training methods, particularly medical school and residency, is that once you put the trainees out into the clinical environment, it gets completely undone. And it's what Fred Hafferty calls the hidden curriculum. So you say, hey, this is the right way to do it. And then, like, this is one of my favorite stories from Dan Duffy, one of my heroes who brought me to the board. He would spend all this time teaching shared decision-making to medical students, and then they would come back 2 weeks later, and he would have them kind of go through a refresher, and they would look awful. He said, we just talked about this 2 weeks ago. What happens? Like, well, I tried that in the emergency room, and the resident told me we don't have time for that. Just simply do X. And so I think part of it's culture again. Part of it's going to have to create the space. I also think the boards can be helpful here by creating tools and mechanisms to help people get better at this. I'm always struck that when I work with older physicians, and we had a couple examples of this at Yale, that when older physicians learn communication skills, they actually find greater satisfaction in their practice. And there's actually some good data around that. Many times the reason they're struggling is that they don't have good communication skills, so they become inefficient. That patients keep coming back, patients aren't happy. When they learn better communication skills, it's a revelation to them. They just weren't taught it. We were taught to be so doctor-centric. And so I think the boards are working to create some tools, but clearly there's lots of opportunity and continued professional development to build this in. So I think the patients could use a certificate program, frankly, so could a lot of the clinicians. And we just haven't done a good job of that. And I think Clarence Braddock's article for me really stands out, that was 1,058 audio tapes of surgeons, family medicine, and internists, and 9% of them even bothered to cover those things. So I think CPD as well as education, but we also need a culture that allows people to have some opportunity to use those skills.
Hi, my name is Barbara Kornblau, and I'm the Executive Director of the Society for Participatory Medicine. What we are, by the way, we are pilot testing a pledge for physicians, which will eventually be extended to other providers. But I just wanted to make the point, in our organization, we treat patients and providers equally. It's an egalitarian organization. And I think that there's a real need for patients to be the ones. With all due respect to the engineer who stood up, I think one of the problems in healthcare is that a lot of things are decided from the top down. And I find, as an e-patient myself, that I've had to train my providers and teach them, like the ophthalmologist who offered my father at 95 3 alternatives for treatment for his macular degeneration and told him to go on the internet and look for it and make a decision. I had to train him that my father doesn't have to turn a computer on. He can't see. That's why he's seeing you. So the computer's not going to be very helpful to you or to him. So you need to give alternatives. You can call me. I am the caregiver, but you can't expect him to make decisions. However, my 25-year-old can make very good decisions if you give him options. He can go on the internet and he can find more information than I can about just about anything in the world. So, I've taught all of my kids. I have 6 children with chronic conditions. They go into the doctor and they ask questions before the doctor opens his mouth. They give their history. I've trained them. They bring their file with them. And I think that that's how we're going to change the culture, is from the bottom up. And physicians will start respecting, there'll be this mutual respect where when someone comes in with the information they need, that the provider, and not just physicians, PAs, nurse practitioners, everybody else in the team will have an understanding of this person is giving me information that's valuable, that's going to prevent medical errors, that's going to improve quality of care, and make the visit faster because I don't have to hunt and peck. They know what's important.
Thank you. Michael.
And Mike Berry from the Informed Medical Decisions Foundation. Thanks all. A lot of great points. I'll just pick up on one that Gary talked about. There is such clinician pushback sometimes around the shared decision-making stuff is okay for college professors, but not really for regular folks. And the importance of asking the right way that Gary highlighted, that contingent on having the right tools, the feeling is quite different. To extend that, in our foundation, when we, in our demonstration sites, actually catch people in a decision window and give them information about their condition, those numbers then go up over 90%. And that seems generalizable across age, educational level, and even gender, amazingly. So again, this notion that the idea is ubiquitous, but people need different kinds of help in their situation.
Thanks, Michael. Dave.
Yes, indeed. Information boosts engagement. How on earth, it just stuns me that this is a surprise and a research finding worth publishing. How on earth can anybody participate in any discussion if they don't have information? And yet, what Kristin said about culture eats strategy for lunch, this is so important. I see this loop, all the conferences I go to, where we say, don't give patients information, they can't understand this stuff, and then they get insulted for not knowing anything, okay? And when I first spoke at the Meaningful Use hearings a couple of years ago, I mean, this is really important, that I tweeted something about, a certified e-patient. It's a great idea, but it'll be for naught as long as patients get smacked down, right, by clinicians, which is why, as Barbara said, the society has a SEAL program with matching pledges. I, the provider, promise to do this, I, the patient, promise to do this. I told the story in my Meaningful Use testimony. Now, 50 years ago, more than that now, good heavens, 60 years ago, my mother had to learn to drive because she had 3 kids and a traveling salesman husband who was never home. And in the early 1950s, a lot of women didn't drive. In fact, the cultural conversation was that women drivers right, were depicted in cartoons and late-night comics with the bumper wrapped around the telephone pole. And indeed, Mom, within a couple of months of getting her license, backed into a pole, put a dent in the bumper. The irony here, my dad said, well, good, I'm glad this happened, in a harmless way so you could learn. The irony is that today, insurance statistics show that women have 1/3 fewer accidents than the men who used to make fun of them. Okay, so while we work on the facts, okay, obviously people perform better when they're informed better. That applies to clinicians as well as patients. But we also really need to work on the culture. Okay, because as long as people think that patients can't understand anything useful, it'll be for naught. So let's do both.
Thank you, Dave. Val, you have a question from the webcast audience?
Yes, I have two. Should I go through both? Okay. The first is from Shilpa Amin, MD. Can the panel and audience address the role of cultural competency and multilingual skills as part of the needed skill sets in our healthcare communications and approach with an increasingly diverse demographic shift in our patient populations? The second question is from Petra Langui from the Schwartz Center for Compassionate Healthcare. What can be done to relieve stress that many caregivers feel today, which can impede their ability to connect effectively with patients and families?
So that first question, I would open that up for both our panel as well as anyone in the audience who has any experience or knowledge in that area of cultural competencies.
We do have data like that in our survey for the Blue Shield. We have data on that in our survey for Blue Shield of California Foundation. We do show that first that willingness to participate in shared decision making is largely the socio-cultural, socio-economic in basis. Individuals who are traditionally less empowered in our society are more hesitant to take an active role in their care. Less educated, lower income, non-citizen, non-English speaking. So cultural competency is a way of getting across the information that levels the playing field. And we do find that these populations desire cultural competency, want to work with care providers who understand where they're coming from, who speak their language. That's an essential element of the communication that is so essential in getting across the information that leads to connectedness, continuity, engagement, empowerment. So we do see that in the data, yes, cultural competency is important. And that's why facilities such as traditional safety net clinics continue, I think, to thrive because they have a specialty in that area.
So the second question about caregiver stress, any of our panel members want to address that?
Yeah, I'm no expert here, but it is a big issue, and it's gonna only grow, with the kind of silver tsunami, that's coming for all of us. I mean, looking at myself, we know that that's a really growing problem. There are some good examples of respite programs. The VA has had a respite program. When I was at Yale, they would give the caregiver some time when they were taking care of a family member. That was huge because they really can experience burnout. So I think we have to be attentive to that. As we have an aging population, we're going to see probably more and more of this, and it can actually have its own health effects. There's some literature that it too, can be not only disempowering but can also have its own health effects. So I don't have an easy answer there. Like I said, there are some examples. They're usually within closed systems, the VA and the military being two of those. But I certainly resonate with the question as somebody who's experiencing some of that now on my own level.
Thanks, Eric. Go ahead.
Yes, my name is Sue Salmon. I am from the University of Medicine and Dentistry of New Jersey, and I just wanted to refer to the concepts of connectedness and the coaching. We have a community health clinic in an underserved area that is really very transdisciplinary in terms of physicians, nurses, and other healthcare providers working together. But perhaps the uniqueness in our model is that we hire and train from the community that we serve community health workers that serve in the capacity of that cultural broker and help the physicians, the nurses, and other health providers understand how to teach from a culturally competent perspective, how to present information, We have teams of physicians, nurses, and other health providers that are led by the community health workers, and they see clients in the community, which is where culture lives. And I think we have to look at getting out of our classic organizational healthcare into the community, valuing many different people on the team that can truly change healthcare. And we have seen a tremendous difference in patient engagement with this model.
Thanks for that, Sue. Victor.
Thank you. Victor Montori, Mayo Clinic. Our team has been working on developing decision aids since 2004. And we've taken the approach of creating very lightweight, very small footprint tools that can be put in front of the patient and the clinician. And the clinician and the patient can then review it together and the tool will contain the options and the risk and benefits of each of them, and they can discuss together and arrive at a decision together in the office. Those tools have been developed with participation of the patients and the clinicians actively through a series of prototypes. And so we don't have the problem of work that usually happens in the way we normally do things, which is go to the conference room, get a bunch of experts, close the door, figure out exactly how you want to do it, refine the intervention to the point that it's perfect, then take it to the practice, put it in front of clinicians, and then write the paper about barriers and the fact that these people do not know how to use your tool and do not know how to incorporate it into their workflow. And we haven't had that problem. And we also haven't had a couple of other problems. The first one is the notion that clinicians and patients will have different knowledge base. They're looking at the same material. They could have other backgrounds, and if the conversation is created, they'll bring those backgrounds to bear. One of the things that we discovered is that if we set up the knowledge level for the patient, it's actually good enough for the clinician. Sometimes we overestimate the clinician's cognitive abilities, and when we try to educate the clinician, for instance, for maintenance of certification or other purposes, we actually raise the bar so high that it becomes impossible for a burnout clinician, which is becoming the average clinician. And so by creating tools for patients, those tools actually help the clinician also stay up to date. The third thing that we've uncovered with that is that even though we're intervening during the consultation, the duration of the consultation does go up, but not massively so. So on average, it's about 3 additional minutes for a consultation, an average of 20 minutes. So it's a small amount, particularly if you don't use the duration of that visit as your denominator, but duration of the relationship, a series of visits in continuity as the denominator. It's a small investment in time that could potentially pay out. The fourth thing that we've uncovered is that most of the demographic determinants of whether somebody will participate in decision-making fall apart. If you actually engage patients by meeting their needs, informational needs, you have young and old women and men participate actively in shared decision-making, and we have video recordings to demonstrate that is the case. And we've done now a meta-analysis of all our randomized trials where we've tested these tools. In the meta-analysis, all socioeconomic differences at baseline in terms of educational levels, actually this thing levels it up after the intervention. The average, and this will be my next to last point, the average age of our participants is 65. So this notion that only young people are interested and keen and are able to participate goes away once you develop tools for everyone. Elderly people are happy to participate, they know what's at stake, and they have a lot more experience to rely on to participate in the encounter. My last point is that a lot of the things that we know about these things come from observation and experimentation of the system as is. And in the system as is, we find a lot of clinicians who've given up, who've learned have learned helplessness, and they feel they're not under control. That it is the cost and the cost containment and the economic realities that are dominating the day, and these things are details. In parallel, there's an industry that is beginning to emerge around patient empowerment and shared decision making that is making these things also an economic, another factor, another thing to consider in the business plan. And it reminded me of a study that we did with our designers at Mayo, where we actually interview patients in the hospital and ask them, what meaningful experience of care have you experienced? And then we collected all that to try to find out what creates meaningful experiences of care for people that are very sick. And to a T, the way in which you can tell there's a meaningful experience was when somebody got out of their way So if rounds came around and then one doctor came back and said, you look confused, you look distressed, what went on? If a doctor on the way home, off the white coat and all that, actually comes back and talks with the patient, is everything clear? Are you comfortable? Talks to the family member who just flew in, but it was late for rounds, comes back, and every time somebody gets out of their way, it creates a meaningful experience. So I would encourage us that when we talk about empowerment and shared decision-making and other things, we keep going back about the fact that these are two human beings that actually by nature will like to have an engagement, will like to talk to each other, and let's not script this, not make it an economic transaction, and make it a meaningful experience.
Thank you very much.
Hi, I'm Danielle Torino from the Substance Abuse and Mental Health Services Administration, which is an operating division of HHS. Eric, I really appreciated your slide that you wanted us to remember, talking about health systems and health populations. And 1 in 5 adults, being that we live in a country where 1 in 5 adults will be diagnosed with some sort of behavioral health issue, whether it be a substance use disorder or a mental disease, we have an extremely vulnerable population. Who don't always know how to have those conversations with their doctors. We deal with a lot of confidentiality and privacy issues. I've spent my entire federal career trying to figure out how to relay the information that I hear at all of these meetings to my population, and I'm having a bit of a problem because I come from a clinical world. Before I came to the government, I worked at a university in a mental health and substance abuse clinic on campus. And if you had paranoid schizophrenia and I tried to tell you and inform you that you had paranoid schizophrenia, you thought that I was out to get you. And so I have a population that's extraordinarily vulnerable. And when it comes to informed patient decisions, the families really need to be on board as well, because a majority of the time, families are the advocates for the vulnerable communities that I have experienced working with. And also along the line of curriculum, there's an extraordinarily large amount of bias that we've heard our consumers talk about feeling from their physical care providers. In a world where we're going to be exchanging health information and my diagnoses are going to be on my electronic health record, do I want my podiatrist knowing that I once tried to commit suicide? And so as we move on with the workshops, I just came up here to kind of plant the seed of the idea of mental health and behavioral health needing to be considered in these processes, because we have a large amount of people that suffer with these conditions who have less access to information than we would think. And that's all I had. Thank you.
Thank you very much for sharing that perspective.
I'm back. I'm perhaps the most engaged patient in the state of Maine. And that's because I've networked with patient safety activists and advocates through the Consumers Union Safe Patient Project. It's a phenomenal project and a wonderful group of people. And about 2 weeks before the 2011 summit, where we all get together once a year, I was diagnosed with uterine cancer and needed cancer surgery. Well, I'm 63 years old, 62 at that time, and I'd never had surgery for anything. I've been very lucky. So I had all of these people to talk with, and I really, truly became engaged. I took a full 2 weeks to make my decision about where I would go and where I would have that surgery. So, and I will comment that it's not easy to be an engaged patient. I was considering 3 different hospitals, and I tried to find out the complication rates for the particular surgery that I was facing, and that was impossible. The infection rates were a little bit easier, but I was particularly blown away by the infection control nurse that said, "We don't have to report those infections until next year." And I said, unfortunately, I have cancer this year. And I did not choose that hospital. And it's awful that I based my choice on that, but it really did turn me off. But when you talked about engaging patients, a couple of things came to mind. Before I went into the hospital to have my surgery, and I had a wonderful outcome, by the way, I'm cancer-free and happy about that, I wrote a letter to the patient safety officer at that hospital, which is probably not too many people have done that. I would suggest it. I told them who I was. I told them I was scared. I wasn't there for a social call, basically. I was there to get rid of cancer. And today I wasn't one of them. I wasn't one of us. I was one of them. Because it is an us and them thing when you're on the other side of it sometimes. And I laid out my expectations. And one of those expectations was that I wanted my husband to stay with me overnight. I only had to be there one night. And nobody ever responded to the letter, but when I showed up for pre-op, I had all kinds of visits from administration. And I was very quiet because I was scared, but they got it. They got it that I didn't just write that letter for myself. I wrote it for everybody. I wrote it for all patients. So I came to mind when we talk about engagement and all of that is that maybe it's time to review patient rights. And rather than these things being ideas and hit or miss, and maybe this hospital will allow you to keep your loved one with you overnight, and that is the greatest source of comfort that I had. But that one won't. And if you're in a semi-private room, you can't have your advocate stay with you overnight. I think it should be a patient's right to have an advocate by their side when and where they want, unless it creates a hazard or puts them in jeopardy somehow. And the other right I think that we should have is the right to our own personal health information, and that shouldn't be anybody's decision. It should be our right as patients to have that information. So a lot of discussions wouldn't even need to be held if they became rights. So,
thank you very much. I'm going to be a moderator of police now and make the decision that on this side, Mark, are you in the back of the queue? Okay, so you'll be the last on that side. And Grace, is there anyone behind you? Okay, all right. We are going to continue with this topic after the break, so thank you. And Perry.
Yes. Excuse me. I've had Parkinson's for 17 years now. Sometimes it's hard for me to get the words out, but I'll give it a shot. My name is Perry Cohen, and I'm with the Parkinson's Pipeline Project. And I want to focus on the issue of change, which was brought up as an issue. I agree with all the stuff it's saying about patient empowerment. But to me, technology is what's going to drive the change. And our friend, Mr. Engineer, had it right. But the other person who commented on that also had it right, that you have to have involvement of the patients in the teams that are getting who are creating the changes. We have an opportunity now with $18 billion or $17 billion going into electronic medical records to do that engineering, so that this is what's going to drive the change, and to get the patients more involved and get the physicians more involved with patients. We also ought to be looking at the personal health records as well as electronic medical records. And I actually was working with a doctor to do that for specialty care, for Parkinson's care. And, well, so the bottom line is that it's specialty driven. Each disease entity ought to be able to organize itself to create the culture and environment, to train the patients and train the doctors and have their own certification system like they do now for like the Board of Internal Medicine. So that's about all I have to say.
Thank you very much, Perry.
Can I respond
Sure.
One of the things about information is we know information alone doesn't change behavior. You need training programs around how to use the information. And one of the things I wanted to make clear is with the personal health record and the new Choosing Wisely initiative by the American Board of Internal Medicine in concert with specialty boards is they're teaching physicians what not to do. At the same time, we've got an indemnified population out there committed to the notion that they deserve service and they deserve expensive service. They deserve the kinds of services they want and need. Teaching people how not to use may be a place to start. What you don't need and what kinds of things that training modules for if you want to know how to talk to doctors about this, link up here or talk to a professional society. But learn how to use information and how to ask better questions, how to ask, do I really need this? Those are things that we still don't do systematically with patients, and I think this is a great opportunity to start.
Thank you. Go ahead.
I'm Turkan Gardenier from Pragmatica Corporation. For many years, I have worked as a health statistician and researcher. And my comment and perhaps question to the panel members refers to the new trend for early intervention and risk-benefit assessment, concurrently developing with genetic marker evaluations, those getting into databases, and in any models I have seen, along with patient data, there's the query about exposure assessment, air quality indices, water quality indices, and they all are in different places. As a family, my husband was the engineer who posed the question. We were at the annual meetings of AAAS, American Association for Advancement of Science, and I heard fascinating presentations on air quality levels and their association with 9/11 calls, especially in July and August, and the number of apartments that had no air conditioning. And also the statistic that because of lack of CPR or adequate CPR, that 90% of the people who were treated, who made the 9/11 calls did not survive. Well, as a senior, if I lived in a metropolitan area and didn't have much air conditioning, I would move, having the flexibility to do so, even before anything happened. And then I delved into the databases for environmental indicators in different areas using geographical information systems, and I couldn't really understand the data that were there. Is it risky? Is it within standard or not within standard? So aside from training patients who already are patients, we also have to work with the databases that exist to individualize the information so that people who are semi-knowledgeable about this can make interpretations for themselves even before going to a physician.
Thank you. Yes.
Hi, I'm Holly Jimeson from Oregon Health Science University, doing a rotation through NIH and Bob Kaplan's Office of Behavioral Social Science Research. I have a comment and a question about the roles and responsibilities leading to defining competencies. So to start with Eric's list of competencies, where the last one was have the physician ask the patient or what their preference is or decision, I want to emphasize that many physicians seem to take that as, well, what do you want to do, being the question, as opposed to needing to make an optimal decision or an optimal, even a recommendation for a patient. You need to understand their values on the outcome, not just what do you think you want to do. They are the experts in diagnosis, prognosis, understanding the probabilities of complications and what the, although oftentimes other patients are more the experts in what it's like to live with a health outcome, and that may be part of important information systems that get at that. But from both patient competencies and physician competencies, I just want to make sure there's an emphasis to not just saying, what do you want to do, but you are a unique individual with your own values and very legitimate differences of opinion on living with complications of treatment and getting that information during the visit or before. Thanks.
Yeah, I'll just quickly respond. I mean, in no way do I intend to say, like, so what do you want to do? You know, I mean, that's the worst thing. And that's, again, that's a skill, right? I mean, it's interesting, even that study, that even what you just said, which I totally agree is not a functional way to do it, that was rarely done, which is fascinating. So even saying what do you want to do is not commonly done. And you're absolutely right. I mean, I think it was wonderfully said by the patient, I apologize, patient like me, you know, you got to know who your individual is. So taking a couple minutes to get a sense of how they view their illness, who they are, is absolutely critical, and that's part of that connectedness, right? And then if you saw one of the first things on the list from kind of Braddock and Wendy Levinson was, you know, to have a conversation, invite them to participate. Tell me a little about who you are, and I want you to help me make this decision. You know, I'm not going to just leave it out for you to lay a bunch of choices. That's, in fact, we know that's not a very functional way. And in fact, you know, Mike Berry's work in decision aids is designed to help avoid some of that. So I totally get it. I'm glad you raised that.
Yeah, I think it begs the question of the definition of what we mean when we start to use these phrases like illicit preference. It's a really good point. Okay, Grace, you're up.
Thanks. Grace Liu, University of California, San Francisco. I appreciate the comments from the panel and from the audience. And one of the things that struck me was the fact that, and I think, Eric, you touched on this, that we have a very disorganized system. Medicine doesn't happen as a system, it happens in a silo. I'm a clinician. What happens with me and my patient happens right then. I'm not in the room with somebody else when they're talking with their patient. And so it occurs to me that we haven't really talked about how, as a clinician or as a patient, how we know we're doing well, how we know that we've achieved what patient-centered care is, how we know we've achieved that we've educated the patient appropriately, that the patient is engaged appropriately, and how we let the physician know, or the hospital know, or the healthcare system know that we have reached the goals that we're laying out here in this conference. So I put that out there as, I don't think there are any easy answers, but I put that out there as sort of a challenge and for comment. Thank you.
I just resonate. I mean, I think measurement, I'm sitting next to one of the gurus of measurement. I mean, I do think we have some things, and like Judy Hibbert, I believe will be here tomorrow, her patient activation measure is actually a very useful tool. We don't use enough of that. I also think, one other comment I just make about system is, we tend to think of the system being the information technology, and I really like the way Paul Batalda and the Dartmouth group think about it. No, it's not the system, it's the facilitator. Information and IT should sit as a hub of information, but systems mostly about how people work together and how, you know, they coordinate and do care as a team over multiple locations. And I think we have to be careful to always think of systems in terms of just technology. Systems is mostly about people.
Thank you. I think, Grace, your point about accountability is really important. We've got to bake that into the whole conversation. Okay, Mark.
Mark Gorman, patient advocate. Actually, this has been a very rich discussion, an excellent panel, and I think certainly exceeded my expectations as a member of the planning committee. But Eric, you actually were here very intentionally as a representative of organized medicine. So, you know, I'm glad that came through. But nobody was trying to put you on the spot. I mean, you got the invitation because several members of the planning committee have been listening to you for many years talk about the concomitant competencies that clinicians need to acquire. And the discussion here today highlighted sort of the tension between everything has to be on the patient's shoulders to learn how to be effective, as well as Dave pointed out, you know, the most activated patient is potentially going to be profoundly frustrated encountering a brick wall. So, you know, we need to find a way to meet the happy median there. You've used the word skill at least once, maybe a couple of times. So just to conclude, you know, when I think about these things, it's a extremely important distinction on this
physician communication skill, competency. It's not a trait. It's not something that somebody got because they were raised in a household and learned to be a good communicator. I mean, once on the clinician side, these competencies are put in the box of being skills. Then you have things that can be taught, you've alluded to that, for which clinicians can be accountable and even, as you just said, measured for having acquired. So, I hope that you and your colleagues in organized medicine will be encouraged to continue your good work. You alluded to, multiple boards here earlier. We have to become collaborators, and I'll have a couple of things to say about that in the concluding panel tomorrow. This business of culture of patients and clinicians being at each other's throats, that's got to change.
Thank you, Mark. That was a nice wrap-up. Okay, I have permission from the powers that be to give you a full 15-minute break, even though we're 5 minutes late. So we are going to reconvene at 3:20. I would like to ask the panel members for the next session to come back about 3 minutes prior to 3:20. And I want to thank Gary, Sherry, and Eric.